Hello, and thank you for joining us today. Today is the first in our survivorship series. I'm going to turn it over to Dr. Jeff Peppercorn, who is a breast oncologist and director of supportive care and survivorship.
So thank you, Devin. On behalf of the MGH Cancer Center and our supportive care and survivorship program, I'm happy to welcome you to this seminar. As Devin said, this is the first in a series. Today, we're going to be talking about advances in the science of cancer care. On February 24th, we're going to be covering lifestyle and nutrition issues. And then on March 10th, issues related to coping with cancer and managing stress. And some of you may note that this webinar is really replacing our usual in-person patient and family survivorship conference. And it's representative of how we've tried to adapt to the conditions of the pandemic and provide many of our services virtually. We're still offering many services, most services in person as well, in terms of social work, psychology, palliative care, even things like acupuncture and massage. But we also have many new virtual services and others that have shifted over to virtual, such as mind-body resiliency programs, lifestyle medicine consultations, parenting in a challenging time, and many others. And we're in the process of launching new programs for adolescents and young adults with cancer, and in revamping our peer navigation program. So there's a lot that's going on, and we hope that any of you who are interested or feeling the need for these services will discuss it with your cancer care team and look at the MGH Cancer Center website, where there's a ton of information about how to access these, sign up, and learn more. So with that said, I want to turn to our speakers. You're going to be hearing today from two outstanding colleagues, Dr. Bardia and Dr. Temel, who are leaders in cancer research at MGH, and they're really among the top researchers in their field internationally. Dr. Bardia is going to speak first, then Dr. Temel. I'll introduce them both in more detail in turn, and then we're going to take questions at the end. If you have any questions, please send them through the chat. We'll try to get to some of them, particularly questions that may be generally applicable to all of the people listening. So with that said, Dr. Aditya Bardia is a medical oncologist specializing in breast cancer and an attending physician at the Mass General Cancer Center in Harvard Medical School. He's the director of the Molecular and Precision Medicine Clinic at MGH in our Breast Cancer Center. And his interest is integrating precision diagnostics and therapeutics, including clinical application of circulating tumor cells and DNA, otherwise known as a liquid biopsy, to improve the outcomes for patients suffering from breast cancer. He's been a national leader in clinical research. He's contributed to the development of a new drug for hormone receptor positive breast cancer and to the recent approval of a brand new type of drug, an antibody linked to chemotherapy, a drug antibody conjugate called sacituzumab govitecan. He came up with that name, I think, just to get me to try to pronounce it, for patients with metastatic triple negative breast cancer, and it's actually being explored in other types of cancer as well. He's an outstanding researcher, clinician, and colleague, and he'll be speaking to us today about translational research moving from bench to clinic. So thank you, Aditya.
Thank you so much, Jeff. The pronunciation was great. Very nice job with the pronunciation. It's my pleasure to be here today. Sorry we have to meet virtually, but at least we can enjoy different Zoom backgrounds. So I'm excited to be here today. I will be talking about science impacting clinical care, translational research, moving from bench to clinic. So over the next 15 to 20 minutes, I would highlight how science has impacted clinical care, giving a few examples where things that were seen in the lab got translated into therapies and then back to the lab. So this loop of going from bench to clinic, back to bench, with the overall goal of helping patients with breast cancer, that's my expertise, and cancer in general. So I'm a medical oncologist and would like to start with a patient story. This is a patient I had seen a few years ago, a 43-year-old female who was initially diagnosed with localized hormone receptor positive breast cancer. Because it was localized, she underwent lumpectomy followed by radiation therapy, then received standard chemotherapy followed by tamoxifen because she was premenopausal. And then unfortunately, about 7 years after the original diagnosis, she noticed shortness of breath, which prompted an evaluation in the emergency department, had a CAT scan, which revealed lung as well as liver lesions, the biopsy of which confirmed breast cancer. So the cancer had returned. And this time it was actually triple negative. It was ER, PR, and HER2 negative. So as recommended for triple negative breast cancer at that time, she received chemotherapy with a platinum. The therapy worked for about 6 months or so, had disease progression, then received a couple of additional lines of therapy, capecitabine followed by eribulin. And I had seen her around this time. She came to our clinic for discussion of clinical trials. And she was a very pleasant lady, and I reviewed everything. I reviewed that, this is what you have. This is the type of cancer. It's triple negative. And the question was what therapy to consider next. So I spoke with her. I said we could offer clinical trials. We could do another therapy. But her question was, why do we call it triple negative? She said, now I've received one therapy after the next, and everyone says I have triple negative breast cancer, but I'm sure there must be something positive in triple negative. And I think she was, making the point that we need to find something positive about things in general. But the thing from a biology perspective that was striking was there has to be something positive in triple negative. There has to be a target that we can go after, that we could potentially inhibit and potentially control this disease. So just choosing one chemotherapy after the next doesn't make sense. There has to be something that is much more targetable. So the first thought I had was, why don't we sequence the tumor? We can sequence the tumor, we can identify molecular alterations that drive the tumor. We've seen successes in other cancers, lung cancer with EGFR and other alterations. In breast cancer, ER, HER2, so we can sequence the tumor and find alterations. So this is exactly what we did. We sequenced the tumor. She had chest wall disease, so it was, from a biopsy perspective, easy to biopsy. And there were multiple alterations that were noted. But unfortunately, all of these alterations are not actionable. TP53, cyclin D, cyclin E. And it's not an uncommon scenario where just by sequencing the tumor, we are unable to find actionable alterations. But a key consideration here is that there is a lack of actionable genomic alteration. So even if there are no genomic alterations, there could still be actionable non-genomic alterations that one can go after and potentially inhibit. And that essentially is the concept of antibody-drug conjugates. An example being TROP2. So TROP2 is an antigen that is overexpressed in majority of triple-negative breast cancers. It's an antigen that is overexpressed in cancers, not so much in normal cells. It's not a genomic abnormality. It's just an antigen, a receptor that tends to be overexpressed in triple-negative breast cancers as compared to the normal cells. We often talk about that cancer is different. Cancer tends to proliferate more. Cancer cell has a lot of alterations that give it the unique property of growing and proliferating. So can we convert this advantage that the cancer has into a disadvantage in terms of targeting it? We know that cancer cells are unique, and those unique things allow it to grow. But if we can target that uniqueness with specific therapies, it's something that converts an advantage to a disadvantage, because that unique thing, if it's targeted, would only affect the cancer cells, not the normal cells. So TROP2 is such an antigen. It's overexpressed in cancer cells, including triple-negative breast cancer, but not so much in normal cells. So if you target that, then you can selectively affect the cancer cells, not so much the normal cells. And it's an excellent target for antibody-drug conjugate. So let's take a step back, and I'll actually go back to history to explain the concept of antibody-drug conjugate. And that's the Trojan horse story. Now, as folks would remember, this is something we learned during middle school and high school, the story about the Trojan horse. After a 10-year fruitless, the Greeks, and inside the horse, there were a force of men that were hidden. the Trojans pulled the horse inside the city. And once the horse was inside the city, the army could come out and open the gates and destroy the Trojans and the city. So it's a similar concept that you allow toxic payload, which is the army in this case, to enter the cancer cells and then release the army or the toxic payload to the cancer cells and thus ultimately affect the cancer cells. So in this case, the Greeks were able to enter, destroy the Troy city, and win the war. And one can draw a similar analogy to the war against cancer as well. It's a property where by selectively targeting the cancer cells, you can improve the efficacy to toxicity ratio. So example of this is sacituzumab govitecan. As Dr. Peppercorn mentioned, it's an antibody drug conjugate that targets TROP2. The antibody is specific for TROP2. It has a number of molecular warheads, the ones that are listed in red here, that are attached to this antibody. And the principle is that the antibody would bind to the cancer cells, which express this antigen TROP2, go inside and then release the payload, the army, if you will, to the cancer cells. Now, this drug also has a unique property. Not all cancer cells express TROP2, but the toxic payload can go outside of the cells and also affect the cells that do not express TROP2. So there is what we call a bystander effect. As long as it gets inside some cancer cells, the surrounding cells that do not express the antigen can get affected because of this bystander effect. So we were involved in the phase 1, phase 2 development of this agent. This is a waterfall plot. Anything that comes down is good. Essentially, each bar represents the degree of tumor shrinkage with this drug, and each bar is an individual patient. So as you can see, for majority of the patient with this drug, there was some shrinkage seen with sacituzumab govitecan. And because there was some shrinkage seen, in general, that would indicate that the disease did not grow. And these were all patients who had received a number of prior lines of therapy, including standard chemotherapy. So even in resistant triple-negative breast cancer, you could see activity with this agent, probably because of this unique mechanism of action. So this led to the phase 3 trial. These are the results we presented last year. This is what we call a Kaplan-Meier curve. The green is the survival in patients who received sacituzumab govitecan, and the gray is the survival with standard chemotherapy. And what is striking is you can see that with the therapy with sacituzumab govitecan, the curve shifts. Patients who are getting the drug in general do much better as compared to patients who get standard chemotherapy. And in terms of numbers, approximately the survival was double with this agent as compared to standard chemotherapy. Just again emphasizing that because of this unique mechanism of action, because of using a different concept, you're able to improve with what's seen with standard chemotherapy. So coming back to this patient enrolled in a clinical trial with sacituzumab govitecan. These are the scan results. There was a lot of disease, as I mentioned, in the chest wall and in the lungs as well. With the treatment, there was a nice response to the point that she actually had a complete response with sacituzumab govitecan, was able to discontinue her pain medications. And this treatment worked for her, not only from a clinical perspective, but also from a quality of life perspective. We also did a biopsy and looked at the expression of TROP2, and there was 2+3+ TROP2 expression present. Again, not all cells express TROP2, but there were sufficient cells that expressed TROP2 that allowed the drug to get in and affect the other cells. Another example of a patient who had just nasty chest wall disease, got the drug and had a response. And again, not only clinical, but also from a quality of life perspective, could derive benefit. So this ultimately led to the approval of this agent for patients with triple-negative breast cancer who had received at least 2 prior lines of therapy. So this drug is available now for patients with metastatic triple-negative breast cancer. And this has also led to interest in other antibody drug conjugates. We talked about TROP2, but there are other antigens that are overexpressed in cancer cells relative to normal cells, such as LIV1 or HER2. And so there are drugs targeting those antigens as well. And so we have, over time, we'll have a number of options to selectively target the cancer cells as opposed to the normal cells. Now, don't get me wrong, these drugs are not without side effects. Because it has the toxic payload, some of the toxic payload can cause side effects, including nausea, hair loss. But the point is that it's an advance from chemotherapy. So we are moving the field forward, and we continue to build on the success. So on that note, how do we move the field forward? It's nice that this agent has a response rate of 30%, but what we want is even deeper responses. We want the percentage to increase from 30% to 50% to 70%. Everyone who has breast cancer should potentially have access to a treatment that is effective. So how do we do this? And I think the answer is science. Trying to understand why do some tumors respond and others do not. And for sacituzumab govitecan, if you look at the mechanism of action, because the payload affects topo-1 isomerase, which is what's involved with DNA replication, if you combine that with a drug that prevents DNA repair, so this agent, when it goes inside the cancer cells, causes DNA damage. If you combine it with a drug that prevents DNA repair, suddenly you have synergy. And that's the idea of combining it with a PARP inhibitor, so there's synergy from a biology perspective. But it is complicated. This concept was tried in the past when irinotecan was combined with a PARP inhibitor, and it was too toxic. And even when we started with sacituzumab and PARP inhibitor, this was too toxic for the bone marrow cells. So in collaboration with a lab led by Leif Ellison, we looked at different strategies of combining sacituzumab with a PARP inhibitor. And turns out that if you don't give the drugs together, you space them out, then you can suddenly affect the cancer cells, but not so much the normal cells. Because with the antibody drug conjugate, you deliver high doses of chemo to the cancer cell, it stays there for a longer period of time, is washed from the normal cells. So if you just wait for some time and then add the PARP inhibitor, you'll be able to affect the cancer cells, but not have much effect on the normal cells. So suddenly you can improve the efficacy to toxicity ratio. And this essentially what's salvaged the clinical trial. And the trial is now going very well, where patients get sacituzumab govitecan first. And in the third week, which is the off week, we add the PARP inhibitor. And with this approach, we are not seeing a lot of side effects, but we are seeing efficacy that we feel is much more than what you would see with one agent. So an example of how science and work in the lab guided the clinic and helped with an approach that we are now using. So to summarize antibody drug conjugates, it's complex. It has the immune component, the payload component, and host factors. And we need to understand all of these and build further combination therapies. The other thing that we need to do is move these agents to earlier lines so we can prevent metastatic disease. And that's another initiative that's ongoing in the Cancer Center in collaboration with Dr. Laura Spring, who leads our neoadjuvant effort, where this drug is being considered for patients with localized triple-negative breast cancer, where they get this drug in the pre-surgical or neoadjuvant setting, with the idea being if we control the disease very well, we could potentially prevent metastases. And the current trial is with this agent alone, and in the future, it would be combined with immunotherapy. Again, the concept being that if we add additional drugs, we could further improve the efficacy. Obviously, we have to look at the toxicity as well, but the neoadjuvant setting is a good setting to look at biomarkers and try different combinations. So the field in general is moving from this concept of one size fits all, which has been the traditional model, to this model of precision medicine, where based on molecular profiling, and it could be genomic or proteomic profiling, we choose precision-based therapies. Another example of a patient who had a lot of disease sequencing identified mutation in the estrogen receptor got a targeted therapy to target that and had a complete response. Now, I do want to emphasize that it is complex. Sometimes we can find genomic alterations that are targetable, but we also have a problem when we find a number of genomic alterations, and it's tough to know which is a passenger mutation, which is a driver mutation. And there are therapies that pretty much could target the various alterations. So this has led to an interest in matching the right treatment to the right genomic alteration, something that's done in a molecular tumor board. The idea being that in a molecular tumor board, you review different things, identify what would be the best therapy for an individual, and then you monitor this with different assays, including circulating tumor DNA. All of this goes into a database, and then you have this loop. The results of the database can then impact future patients. And that's the clinic that we started a couple of years ago, the breast map clinic. The idea is that once we have the genomic results, we can discuss and identify what therapy potentially would work best for an individual patient. And all of those results then go into the database. So we learn from our successes and we learn from our failure as well. So we constantly get better. For a patient coming in the future, we learn from what's happened in the past. And now this concept is being expanded to the community as well with this virtual map service where anyone in the community linked to the MGH network, if they have a patient who's had sequencing, could send an email to this listserv. We discuss internally and then provide the recommendation back to the provider. So in the final few minutes, I would like to touch on another concept, which is, can we actually avoid metastatic disease? So if you come back to this patient story, in 2011, she had lumpectomy, and then 7 years later had metastatic disease and had received 5 years of tamoxifen. So the question is, why did this patient have disease recurrence despite all the standard treatment? And should we have considered a longer duration of tamoxifen? This disease occurred after 7 years. What if it had come after 10 or 15 years? How long do we give our adjuvant therapy for? And this is a major problem in breast cancer in the adjuvant setting. Late recurrence or recurrence after the first 5 years. And conceptually, if we think about this, it's like the cancer has two cells, the red cells and the blue cells. The red cells being the proliferating cells and the blue cells being the dormant cells. It's these red cells which cause recurrence just after surgery. But it's the blue cells which remain dormant for a while, and then after 5 or sometimes even more than 5 years, start proliferating. It's almost like these seeds under the soil that are present, and under the right environment, they can germinate. The question is, how can we find these cells? One strategy to find these cells is to actually detect them in the blood. And that's a major initiative that's ongoing in the Cancer Center, which is to detect tumor cells in the blood. There's a chip developed by Daniel Haber and his team, which is a very sensitive test to detect circulating tumor cells. I will not go into the detail about how it works, but the basic idea is to sort out the circulating tumor cells from the normal cells. We often say that finding circulating tumor cells is like finding a needle in the haystack. So the concept here is to remove the haystack so that the needle is left behind, and then you can find the needle. So this is one strategy. The other strategy is to find the fragments of the cancer cells. When cancer cells are circulating in the blood, many times they dissociate, so you have tumor fragments that you can detect. And this is a concept that's based on the idea of developing personalized tests. You sequence the primary tumor, identify genomic alterations that are specific to the tumor, and then you just detect those genomic alterations in the blood. So developing a personalized assay that's specific for an individual patient. And so, in general, this all started in the metastatic setting, but slowly we are moving all of these assays in the localized setting so you can actually detect cancer cells or cancer fragments before a patient develops metastatic disease. So if I come back to this principle, the idea is that you monitor after surgery So the first instance, when the dormant cell is trying to become a proliferating cell, you can detect it. When the cancer cell is dividing, it'll shed circulating tumor cells, it'll shed circulating tumor DNA. So with these assays, you can detect those fragments and those cells, and then at that time intervene. So rather than giving everyone 10 or 15 years of a specific therapy, you monitor. And when you're seeing that the cancer is trying to rise, that's the time that you intervene with a specific therapy. So this concept is not ready for prime time yet, but it is something that we're evaluating in clinical trials. An ongoing trial called the LEADER trial, where patients who are on endocrine treatment, and they could be on endocrine treatment for 2, 5, 7 years, as long as a patient is beyond the first few years, checking for circulating tumor DNA. And if the circulating tumor DNA is present, patients have access to a second agent, a CDK4/6 inhibitor, with the primary endpoint being, can we clear the circulating tumor DNA and potentially prevent metastatic disease? There's a similar study that would be launched in triple-negative breast cancer as well. So the idea being, with better monitoring, detecting the first time that the cancer is trying to grow again, and at that time intervening, so essentially nipping the cancer in the bud. So to summarize the precision medicine concept, it all started with finding the right targeted therapy for the right tumor. But over time, we've learned that the cancer is complex. There could be multiple clones. There are analytical considerations. There are coexisting alterations. And we're moving from the right targeted treatment to the right regimen for the right patient based on the right test at the right time. I'd like to thank my mentors, guide, collaborators, colleague, Dr. Peppercorn, Dr. Temel, the research team, and various funding sources, as well as my gratitude to patients. Clinical research cannot happen without partnership with patients, and patients are the true volunteers in clinical research. Thank you so much for your attention.
Great. Thank you so much, Dr. Bardia. Fantastic presentation, and hopefully everyone listening and watching today captures the excitement, hope for the specific interventions you talked about, but this type of approach that we're seeing throughout cancer. So again, if you have questions about that for Dr. Bardia, or if you have questions as you hear Dr. Temel talk, send them through the chat. We'll try to get to some of them at the end. I'm now going to turn to Dr. Jennifer Temel, who is the Director of Cancer Outcomes Research and the Education Program at the MGH Cancer Center and a Professor of Medicine at Harvard Medical School. Her research focuses on improving the care and outcomes of patients with serious cancer and their family members. Dr. Temel's research demonstrating the benefits of early involvement of palliative care for patients with advanced cancer changed the practice of oncology care around the world. It's really transformed the way this has been integrated, affecting people in Europe and everywhere else. In addition, Dr. Temel has been recognized with multiple awards as an outstanding teacher and mentor who's trained many of our top researchers addressing challenges in patient care and cancer survivorship within Mass General. And incidentally, I've had the privilege of knowing Dr. Temel since our days in fellowship, which are just a few years ago now. So it's an honor to introduce her talk entitled Science Impacting Cancer Care, Supportive Care Research.
Great, thanks so much, Jeff. And thank you guys all so much for coming today and for being here. So Aditya started off with a patient story, and I'm going to do things a little bit differently. And I'm actually going to start with my story, because I get asked by colleagues and patients and their families all the time, how did I become interested in supportive care research? It's not the most common type of research done in oncology. People always want to know how I ended up doing this. So when I was a young child, I always dreamed of being a physician. For those of you in their 50s, you probably had a Fisher-Price doctor kit just like this one. This one is the exact same one that I had. But as I sort of grew up and went to college, being a physician just didn't feel like the right path for me. It didn't feel like it was, the way I was moving forward in my career. So I was actually an agriculture major of all things, which meant when I graduated from college, I had no idea what I was going to do with my life. So I actually moved to St. Louis and took a job working in a laboratory. I thought maybe I would be a scientist. And my laboratory was at WashU in St. Louis, which is a wonderful hospital. And sort of fortuitously, my lab happened to be located in the main hospital building adjacent to the cancer center. So when I walked to the car or walked to the cafeteria, I always walked through the cancer center. And I noticed after the first few weeks of being there that when I would see patients waiting to be seen in the cancer center, they often looked like they were very uncomfortable, physically uncomfortable, feeling distressed. And also the family and friends with them also felt distressed, looked distressed. And after kind of weeks and months of walking by these people, I really felt a strong sort of pull or desire to help them, to kind of make their lives better. And that was why I decided to go to medical school. I decided to go to medical school to be an oncologist. So about 10 years after that, I was in Boston, I was working at the Harvard Cancer Center, and thought, well, maybe there's been some improvements. Maybe, I was a kid back then and 10 years ago, things were different. But I saw the same patients and I saw the same caregivers. And I knew that as a physician, I could personally help my patients and their families. But I also wanted to see if we could do research to help patients and their families, not only in Boston, but around the state of Massachusetts, around the country, and around the world. But when I sort of looked at the research that was being done at places like Mass General, it was the amazing research that Aditya talked to you about. It was all focused on treating patients' cancer. So for example, as a lung cancer doctor, all the research that was going on was focused on treating the cancer. But nothing was really focused on treating how the patient's cancer impacted their relationship with their partner or their other family and friends, their career or ability to work, their ability to travel, enjoy their hobbies, and really their identity. And so out of that desire, I started the Cancer Outcomes Research and Education, or CORE program for short. And really our mission is to conduct innovative research and educational programs to improve the experience and outcomes of patients and caregivers across the continuum of cancer care. And it's very important to us that we are focusing on all patients who are at risk or touched of cancer and their caregivers. And so when we say across the continuum of care, we're talking about individuals at risk of cancer, patients who are living with a cancer diagnosis, and then patients who become survivors and are cured of their cancer, or those individuals who unfortunately die of their illness. And again, we want to focus not just on the patients, but also the people who love them, their family and friends. And so the objectives of the CORE program are to increase health behaviors like exercise or smoking cessation that reduce the risk of cancer. We also focus on improving care delivery. How do we manage patients? How do we treat their symptoms? How do we improve their quality of life for patients and caregivers throughout their illness? And then again, focused on cancer survivors, we want to make sure that after cancer treatment has ended, patients are getting the support they need for both their physical symptoms and their psychosocial distress. So that is a pretty tall order. So you now might be thinking, well, how does CORE accomplish this very large goal? And I can say that as an oncologist, I certainly couldn't accomplish this goal on my own. And really how we do this is we bring together people of all different disciplines. We certainly have oncologists on our research team, but we also have nurses, we have mental health clinicians, psychiatrists, psychologists, social workers, and we have palliative care specialists. And bringing all of these types of specialists and care providers together has allowed us to do what has been coined transdisciplinary research. So basically, by bringing together individuals that have all sorts of different expertise, we can create new innovations that integrate and move beyond discipline-specific, such as oncology-specific approaches to address problems. So now I just want to transition into one of the ways that CORE has performed science that has impacted cancer care, and that's in the area of early palliative care. So before I talk a little more about the research we've done, I know that many of you may not be familiar with palliative care or may sort of have misconceptions about what palliative care is. So I just wanted to start with a quick definition. This is a definition by the Center to Advance Palliative Care, and it's my favorite definition because it just makes palliative care sound really awesome, which it is. So palliative care is medical care for patients living with a serious illness. It's care focused on providing relief from the symptoms and stress of illness. And the goal is to improve quality of life for both the patient and their family. So it's actually one of the only medical practices where the family is part of their care definition. It's provided by a team of clinicians who work together with a patient's other doctors and nurses to provide an extra layer of support. And it's based on the needs of the patient, not their prognosis. And it's appropriate for any patient, regardless of their age, stage, or the goals of their treatment, meaning whether the treatment is to cure their cancer or help them live longer with their cancer. So again, there are a lot of misconceptions about palliative care. Many people think that palliative care is only for patients who are near the end of their life. They think it's the same as hospice care. They think if you're doing palliative care, you're giving up, or that you can no longer receive cancer care or treatment. And again, these are misconceptions because when we go back to the definition from the Center to Advance Palliative Care, it's an extra layer of support. The goal is to provide relief, improve quality of life based on the needs of the patient, appropriate for any stage. So you might also be thinking then, well, why are these misconceptions about palliative care? Like, how did this come? And the reality is palliative care did grow out of hospice. And for those of you who aren't familiar with hospice care is for patients who are in the last months or year of their life. And it's really care dedicated to making sure that patients and families have the support that they need, often in the home when someone is near the end of life. So again, it started from hospice. And in addition, at its start, palliative care really was practiced predominantly in the hospital, and they were called upon to see very ill patients. So again, if we think about kind of the historical role of palliative care in oncology, in the hospital setting, if patients were admitted to the hospital and the oncology team was having difficulty controlling symptoms such as pain or shortness of breath, or if the patient was near the end of life and the oncology team was struggling with what to do with their management, they would call a palliative care consult. Additionally, as I mentioned, in the home setting, for many decades, many patients who are near the end of their life receive hospice services prior to death to allow patients to be at home prior to their death. But when we think about this care model and we think about kind of the illness trajectory for a patient with a serious cancer, like lung cancer that has spread or metastasized, and we think about what their experience is, we know that when they're diagnosed with their cancer, they often have troubling symptoms like shortness of breath or cough or weight loss. And then they also have worries or distress about the diagnosis and what it means for them. As they go on with their trajectory and start cancer treatment, they can have side effects of their cancer treatments. At the same time, they're navigating what their diagnosis means for their family, their friends, their work. And then if the cancer therapy no longer works, they often experience increasing symptoms. So if the cancer grows, they can have more pain and fatigue. And at the same time, they're coping with the changes in their physical health and functioning. And then as their cancer worsens, they might need greater help and support, and they face difficult decisions about their medical care. So if we turn to this trajectory and focus on that historical role of palliative care, again, palliative care might see patients if they were admitted to the hospital or at the end of their life with hospice care. But what this care model did is it left patients struggling with their symptoms, their side effects, their declining health, their anxiety, their changing relationships and identity, and care decisions without adequate attention and support. So what we decided to do was move palliative care upstream, say, you know, they're great doctors and nurses, their intentions are good, they're really helpful, but if they only see people in the hospital or at the end of their life, they're really not maximizing the benefits that they could have for patients and their families. So let's see if we can bring them earlier in the course of disease and have them manage patients along with oncology. Now, you might be thinking, well, isn't it oncologists' job to do those things? And we know that oncology does a great job in many cases managing patients' physical and psychological symptoms. So we would hope that palliative care would collaborate with oncology to manage symptoms, but that they might play a greater role helping patients understand with and cope with their diagnosis and prognosis and some of the difficult decisions that patients and families often need to make when they have a cancer diagnosis. Again, we talked about that palliative care really does focus on the family. And while your oncologist might sort of ask your partner or your child how they're doing, they really focus mostly on your health. But an important thing to remember is, this can't be at the exclusion of cancer care. So when you or a loved one has cancer, of course, your priority is making sure that they're receiving the best possible cancer treatments. And so this care model really needs to be collaborative and integrated. This isn't an either or. In fact, this picture in black and white is a model that sort of described how we used to do things, which basically says you're either getting cancer care or we care about your symptoms and your quality of life. And clearly that makes no sense. So again, the model that makes sense if we really want to support patients and their families is palliative care and oncology care working together in a collaborative and integrated fashion. So for the last 15 years, investigators in the Cancer Outcomes Research and Education Program have been studying this integrated palliative and oncology care model. And at this point in time, we've studied the role of palliative care for patients with many different types of cancer, including lung cancer, pancreatic cancer, breast cancer, patients with a serious type of blood cancer called leukemia, and patients undergoing bone marrow transplant. And in these studies, we've focused on what are called patient-reported outcomes, which means we ask patients about their symptoms, their quality of life, what their mood is like. And these are the most important outcomes for us because, again, the whole goal of this is to improve the experience for patients and their families. And what we found is that by early involvement of palliative care, patients have better quality of life. They have lower depression, they have less anxiety, they have less post-traumatic stress, they cope better with their illness and their prognosis, and they communicate better with their clinicians. I didn't want to show too much data because I know that can be tricky to look at, but these are just two representative graphs from one of our studies. This one happens to be a palliative care study in patients with leukemia. And if you look at the graph that says quality of life, all of the time points at the bottom, that's just looking at the patients over time. And in the diagram, the palliative care intervention is in orange and the usual care is in blue. And on that quality of life measure, higher scores are better. So you can see at the entire time of the study, at 2 weeks, 4 weeks, 12 weeks, 6 months, patients who were receiving palliative care, their quality of life was better the entire time. Now, if you look at the anxiety graph, for the anxiety graph, lower numbers are better. So in this one, you can see that the orange line is below the blue line, but the entire time, patients who were receiving palliative care had less anxiety. Pretty amazing. We've also shown other benefits of this care model. It helps caregivers. They feel less distressed when the patient is getting palliative care. We've shown that survival may be improved by this better attention to physical and psychological symptoms. And for patients who have very serious cancers who die of their illness, we've shown that palliative care ensures that they have higher quality of care at the end of their life. Based on this work and work by others, early integrated palliative care is now recommended by every national cancer organization, including the American Cancer Society and others. Now, I was very glad that Aditya showed a similar slide to this, where this sort of old-fashioned model of everyone getting the same treatment, and now we know that we need to personalize care. And I would say where our field is moving forward is to personalize supportive care or palliative care. So we know all patients with serious cancers aren't the same. And so what we want to do is really center their patient care based on their healthcare needs. So if they have a very serious cancer that's causing them a lot of troubles, we want to involve palliative care early, and we want palliative care to be very involved. But for example, Aditya talked about a patient with breast cancer who had periods of time where she actually felt quite well because her treatment was working well. So for that patient, we might only want to integrate palliative care at times where they have high need. So again, the field is really moving towards trying to tailor or center supportive care based on the patient's needs. And then the last sort of innovative study that I wanted to mention, it sounded a lot more innovative before COVID, but now you all know that many patients are having video visits. But prior to COVID, we started this very large study that's actually taking place at 20 sites across the country and enroll over 1,000 patients, looking at comparing palliative care that's delivered in person, the old-fashioned way where patients actually come into clinic, versus telehealth using video visits so that patients and their families can stay at home but still receive palliative care services. So with that, I will end, and thank you all very much for your attention, and I'm happy to answer questions.
That's so great. Thank you. Thank you, Jennifer. Yes, it's telehealth was really an innovation a year ago, and then we were forced to quickly adopt it. So do send your questions along in the chat, and Devin and I will screen them. We had one question come through for Dr. Bardia about, is there a role for circulating tumor DNA to identify microscopic metastatic disease in newly diagnosed patients with breast cancer prior to chemotherapy? Do you want to?
Yeah, absolutely. So the question is about the role of circulating tumor DNA to identify minimal residual disease or micrometastatic disease in someone who's diagnosed with breast cancer before you can see any radiological evidence of disease. The assay is there, and actually that's a study that we are doing at the MPH Cancer Center in patients who are receiving pre-surgical treatment. So in those patients, we're looking at the evidence of circulating tumor DNA before they start treatment, and then seeing if that gets cleared with the use of pre-surgical or neoadjuvant therapy. It's still in a research setting, so I would say it's not ready for prime time. It's not ready for use in clinical practice. But if this proof of principle is established in the future, potentially this could be something that's done in routine clinical practice.
That's great. Thank you. I mean, I agree with you, and hopefully the audience, it's clear that this is all research right now, but this is getting closer to what I've called the holy grail, which is how can we tell who really has residual disease and who needs therapy and who doesn't, as opposed to just risk management strategies. So it's really exciting work. For Dr. Temel, we've had a couple of people just chime in on how much they've appreciated palliative care, which your work has contributed to. So there's a question here. Perception of palliative care is still widely seen as either giving up or people and families don't know the term. And that's true. I've done some research. People just don't, it's amazing. And people just don't even know what palliative care is, even if they don't have a preconception. And when they have heard of it, they often have the preconceptions that you mentioned. So even with our ability through social media and the medical community, are we doing as well as we can? So can you comment where we are and where that's going? That was my question. I know, how influential your work has been in the academic community and the clinical community, but in the integration into clinic, where are we and where are we going in that area?
Yeah, I think these are all really good points, and I think it's kind of a complicated thing because to some extent, we don't want to divorce palliative care entirely from hospice and end-of-life care, because again, like all things, these are on a continuum. So we really want to help their families understand that sort of hospice is a form of palliative care, but there's palliative care that can be done prior to that. I think there are a lot of national organizations trying to educate patients and families about these terms and what they mean, but I do think it's very challenging. I feel grateful that here at MGH, we've done an excellent job, and many of our patients and families really do understand this distinction. So I really think that's the way forward, is we just need to do a better job educating our patients and families and making sure that our primary oncology providers, our physicians, our nurse practitioners take the time to explain to patients and their families about how palliative care can help them and benefit them as they kind of navigate their cancer diagnosis.
Great. We have one very practical question for you, which is, your palliative care telehealth study still open?
It is open. So as I mentioned, it's going to enroll 1,250 patients, and we have enrolled 715 patients. So we have about 500 more to go, and we hope that that will finish up in about a year and a half.
Great. And if people are asking because of interest for them or a family member, I guess talk to your clinical team. But yes, it's as a way to get attached to the study. So, and similarly, there was a question for you, Dr. Bardia. Is there a clinical trial of ctDNA after surgery? I think this is getting at, is this ready to go even in the research phase right now to help clinicians and patients make decisions about whether they should do chemotherapy or not?
From a research perspective, yes, we actually have 3 different clinical trials that are currently open. One is for patients with hormone receptor positive disease who've completed surgery and are receiving standard adjuvant endocrine treatment. There's a separate pre-screening consent which allows for detection of circulating tumor DNA. And if it's present, then you're eligible for the main study. If it's negative, that means you don't have that and you don't need the additional therapy. The second one would be for patients with triple negative breast cancer, and a third for patients with HER2 positive breast cancer. So there are studies for the different subsets of breast cancer, but I would emphasize again, as you mentioned, it's in a research setting at this time.
Okay, and one more question for each of you. So Aditya, just to follow up, someone asked, and I know you're a breast cancer clinician like me, but are there these studies going on in colorectal cancer? Dr. Temel may be able to answer, is this happening in lung cancer? People looking at ctDNA?
So I can speak a bit about colon cancer and would defer to Dr. Temel about lung cancer. It's my understanding that there are a couple of studies going on in colon cancer in patients who've completed surgery. Dr. Aparna Parikh is leading those studies. It's a similar concept to breast cancer. Can we detect minimal residual disease and if present, act on it to prevent metastatic recurrence?
Yeah, we have very similar studies in the lung cancer program, basically using the circulating tumor DNA to be an indicator that we need to intensify or increase our therapy to try to make sure that we're killing all the cancer cells to increase the chance that the patient is cured after, for example, surgery.
Great. And a final question for you, Jennifer. We've talked about early palliative care. There's many exciting interventions being looked at in CORE, from helping people with their sexual health to apps that help them now, with mental health challenges, navigating adherence. What do you see as sort of the low-hanging fruit for translating the research that you and your team are doing into the clinic?
Yeah, I think that's a great question. I think really what we're trying to do now is make sure that these types of services are more accessible to patients and their families. So again, telehealth is one way to do that, but other ways to do that are, our favorite activity, which is our mobile phone, is developing, for example, mobile apps that give patients education, support, information that they need. Because again, at Mass General, we're very lucky. We have palliative care clinicians, we have social workers, we have all sorts of people, acupuncture, but we know that at most cancer care settings around the country, those types of clinics just don't exist. So I think where we're moving is to access. How do we make sure that as many patients with cancer and their families can receive the support and care that they need?
Great. All right. Well, thank you both so much. And thanks for all of you for listening and participating. This is going to be available on the web so you can share it with family and friends. I definitely have patients of mine that I think would love to hear both talks. So I'm really glad we recorded this and did this today. So thank you very much.
Thank you.
Thank you.
Thank you, everyone.